Thank you for joining us today on CCM Health Live Podcast. I am Dr. Avinash Jayaswal, Chief Medical Officer of CCM Health. On today's show, we will dive into one of the hot topics in value-based care, which is preventive management of pain through the use of second-line treatment strategies. And today we're going to talk to Dr. Patrick Ryan about modern chiropractic techniques and the Gonstead technology, and how in population health and first line of treatment, where we come in, we're able to achieve pain reduction, quality preventive care, and reduction of healthcare costs, which is, of course, the driving force and the model that we follow. But first, like every time, we are joined by Dr. Baran Erdik, our own advisor on regulatory compliance with CMS, and he will guide us through some of the new releases on regulation. Welcome to the show, Dr. Erdik.
Thank you, Dr. Jayaswal. As always, the pleasure is all mine. So it's been another busy 2 weeks. First, CMS has proposed a new Medicare physician fee schedule. And what do you expect when you see new schedule, right? With the inflation and everything, you would expect to see some raise. Nope, not the case. So with the conversion factor, there's about $1.50 decrease, and that at the end of the day amounts to about a 3% decrease, rolling back the increases that were made with regards to COVID-19. So in light of the pandemic, in light of the nursing costs increasing, inflation and everything, they are now proposing a decrease in physician reimbursements. So
we're talking about in-office visits, right?
Both. It covers all of that, but mainly in office, correct.
That kind of makes sense, because in office is not the strategy with Medicare is trying to take, but please.
Correct. So ultimately, right, there's going to be a lot of backlash. We are just now starting to see the backlash from physician groups, but we'll see if this is here to stay or not. And then the same thing goes with ACO. They've also proposed a lot of changes to the ACO program. So they are trying to get a policy to include advanced shared savings payments to some of these new shared savings ones. So basically, they're saying that if we pay these programs upfront, then they can support patients' social needs and encourage providers in rural areas to join ACO. Because one of the main issues since the inception with ACO has been that more physician groups or more groups with patients in well-off areas have been joining these, not the ones where you need them to in middle of nowhere in a rural state, if that makes sense.
Sure, of course. So the whole idea is that value-based care brings value, right? So if you're looking at, a place like, so some good parts of New York, there's a lot of good parts of New York, they are not underserved. But there are other parts of New York that are severely underserved. And then, the US is a very big country, so you have parts that are dangerously underserved. So yes, this is, again, in line with what they have been proposing all along.
Exactly. I mean, isn't it interesting at the end, whenever you and I talk about the regulatory changes, at the end of the day, we come back to value-based purchasing and then maybe even chronic care management. So it is interesting, and I think this is all showing the power of it as well as the power of the triple aim, right? That's been the goal of US healthcare since early 2010.
Totally.
So in another change, there's been an interesting interview or quotes from the CMS Chief Medical Officer, Dr. Lee Fleischer.
Sure.
So basically, there's been a lot of issues during the COVID-19 pandemic, mainly with acute care facilities, and there's been chaos. They've been fined for issues with regard to infection control, for lapses in patient rights, and everything about that. So there's been about $300 million in financial penalties to about 750 hospitals that are considered the worst patient safety track record. So the CMS Chief Medical Officer went on record and said that the safety metrics that the CMS measures to account for the pandemic, he understands that this affected the hospital systems, may be the staffing, may be the sudden influx of patients. So they want to keep patients, payers, as well as insurers happy. So at the end of the day, they're debating whether they are going to waive all of these payments or not. So I think if they are going to be waiving those payments for acute care facilities or at least discussing about it, then the rest will come to that if as a physician you've been audited and you're looking at some sort of penalties, or if as a ACO you're looking at, if whatever, then they may be willing to discuss waiving of those penalties.
Mm-hmm. Very
If that makes
specifically, sure, absolutely. It's very, Chris, what is, something which will immediately make sense to some of our current providers, in your opinion, as far as emergency waivers? What about MIPS? Let's talk about
sense.
the good old,
From
meet
an
and
emergency waiver perspective, we discussed this last week and the week before that. So they are here to stay. They have signaled that they're going to be extending these emergency waivers. So with that, just again, I keep saying that just be prepared for the fallout when the public health emergency ultimately expires. It was most recently renewed in April 2022 and was supposed to expire late July. But we were always told the Biden administration was going to give a 60-day notice before this expires, and they had not given that notice, and then they've come out yesterday saying that they intend to extend this public health emergency. With that, there's a lot of changes with regards to Medicare, Medicaid, CHIP, as well as just private health insurance as well. So a lot of this is particular to COVID. Some of this has not been particular to COVID. It's been particular to telehealth visits,
okay,
or just the expanded list of Medicare services that could be provided via telehealth. So they are all here to stay for now. But as always,
okay,
my guidance to the providers is that be prepared for the time when this ultimately expires, because you may have gotten used to the benefits of this in the last 2 years,
yeah,
including a lot of your patients still being insured.
yes.
And the second this expires, that's all going away.
So what is the timeline? 90 days?
The timeline is it looks like it's going to be extended until October, November, and then they will probably reassess. But with the BA5 and everything, I really don't know. Hopefully, it dies down back then. That we are again discussing the non-extension of these emergencies. But for now, it is still here to stay.
Absolutely, yes. We are not out of the pandemic. That is, we'll get back to that at some point, I guess.
Correct.
Section
Uh,
1115. Oh, sorry. Go ahead.
Well, yes, but I can just mention another Medicare change that a lot of your primary care physicians may benefit from, I guess,
Mm-hmm.
is that Medicare is now going to cover the full cost of a colonoscopy if a non-invasive fecal test is positive. So there have been
Okay.
changes in this because a lot of primary care physicians were hesitant to just prescribe a non-invasive fecal test
Yes.
because it wouldn't necessarily have meant that a colonoscopy was going to be covered. So there've been multiple meetings, a lot of pushback. So now after a positive fecal test, a colonoscopy is going to be covered. And this can be considered one of the quality metrics you can choose under the MIP. So
Okay.
in my opinion, it's much easier to achieve that quality in that aspect now, because a lot of people are automatically turned off by the name colonoscopy. So now you can give them another way. Hey, do this at home test,
Yes.
ship
But
the stool sample to the lab, and then you can take it from there.
it's three negative, right? For the fecal test. You need three
Correct.
negative, right? So as long as
Correct.
you have one positive, your colonoscopy is paid for.
Correct.
Gotcha.
Yes. Granted, this will take effect in 2023, but still.
2023.
So
Okay.
another thing I wanted to mention is Section 1115 waiver.
Sure.
So basically, that's a catch-all, right? So it's under the Social Security Act. It gives the Secretary of the HHS to waive provisions of healthcare welfare programs under Medicaid and Medicare. So basically, it gives like a expanded eligibility to Medicaid. So a lot of these have been approved, and even in red states, a lot of this has been approved. And it looks like a lot of the data that is coming out directly
Mm-hmm.
is in support of the waiver staying. So for our providers, that means the more people that go on Medicaid,
Hmm.
the more interesting the billing landscape will be. But it is here to stay, even in non-expansion states. For example, Georgia is waiving retroactive eligibility, or Idaho is waiving condition eligibility on work requirements. So there's just going to be more and more of your lower socioeconomic, possibly patient population that may have fallen through the cracks that are going to be on Medicaid now.
Tell us about population health. This way, what will change on the Medicaid side?
So from a population health, it's always in the last 5 to 10 years, it's always been the way of basically, are you going to expand Medicaid versus you're not going to expand Medicaid? So before the Biden administration, a lot of these waivers were automatically granted. If you wanted to like get people a tobacco premium surcharge like Indiana has, that would have been automatically approved, or that would have been approved under the older administration. In December 2021, Biden administration notified states that if they had any premium requirements, that these were not going to promote the objectives of Medicaid. That yes, from political perspective, they may look good on your agenda for your state, but from a population health perspective, these were not going to do anything, right? What good does it do if you charge these already poor people a tobacco premium surcharge? Are you really going to get them to quit smoking, or are you going to get them to go uninsured? So at that point,
Hmm.
they were still giving extensions for states that had been previously approved and had some sort of premiums, like Arkansas or Montana. CMS gave them a 1-year phase-out period, including Georgia, that had yet to implement the premium requirement, that it was withdrawing the authority to charge premiums. And we are back to the part where they are going to be just canceling these premium requirements.
The only thing that works with tobacco quitting is actually the raising of the prices. None of the ads and stuff are effective. But again, that's another.
Correct.
Yeah.
And it hasn't just been tobacco, right? There had been interesting, like, with premium surcharges or work requirements. I mean, these people may be already full-time employed, but with the minimum wage, they may not be able to afford anything, or they with long COVID or disability or taking care of someone, they may not be able to work full-time. So a lot of these have been more political versus enhancing population health.
Mm-hmm.
But the current administration has said enough with these 1115 waivers. We are not doing this. Your time has run out. So even if a state is not expanded, I think we're just going to see more and more of the population going on Medicaid, especially after the public health emergency runs out, and then the extra for the marketplace healthcare plans, the extra cost subsidies that we have been getting run out, then more and more people are going to be pushed to Medicaid versus just trying to stick it out on themselves as an uninsured. So our providers should be ready to see more Medicaid patients in the near future.
Tell us about the Medicare coverage changes then.
So
In general.
the colonoscopy had been the main part, but I think with the uh, pay changes, etc., they also interestingly proposed a change in dental coverage. So they are trying to expand dental services, and I think that's also uh, going to we are also going to see that they're going to be enhancing treatments that have not necessarily been covered under Medicare, and that can be opioid treatments or mobile units like vans or clinical psychologists, licensed social workers as a part of the primary care team, or even chiropractors like Dr. Ryan, or other previous specialists or professionals that had not been covered under Medicare. So I think going forward, the Congress is trying to see Medicare as a wholesome health coverage, not just, oh, you get sick, we pay for your visit at the hospital,
Sure.
but instead, oh, we need to take care of your health so you don't actually go to the hospital in the first place.
Of
So
course.
I think total coverage is the first step, including the proposal of the provisions with expanding the behavioral health, as well as paying psychologists and social workers as part of the primary care team.
Excellent. Which makes sense because, when you're looking at fee-for-service has been the reason why, the value-based care and coming out of the Affordable Care Act. So if they're not going to increase in office visits because that's not the way they want to go, especially right now, we're talking about, prices are going off the roof across the board. So this is not a time where things that have been challenged are going to be, incentivized. On the contrary, first line
Exactly.
treatment, yeah, go ahead. Yeah.
So basically, if you're a primary care physician out there just doing fee for service and then just seeing sick patients, you need to take a hard look at yourself and say, is this sustainable in 5 years, in 10 years? Am I still going to be able to make it? Am I still going to be able to bill? You need to slowly move on to preventive services. You need to maybe start taking care of the patients as a whole unit. I mean, do they need opioid treatment, right? Do they need some sort of social worker? Maybe they are homeless, they don't have access to a fridge to put their insulin in, so they can't keep up with their diabetes. So you
Social
need to
determinants
not
of
just
health.
treat the,
Yeah.
exactly, you need to not just treat the disease, but treat the patient.
Absolutely. Dr. Erdik, it's been, as usual, a pleasure. Thank you for those insights. And we will continue our discussion in 15 days. And but please stay if you can. Love to have you just hang around if you can. We are now joined by Dr. Patrick Ryan, who is Gonstead Fellow and Clinic Director of Total Life Chiropractic and Wellness, with whom we will dive into the management of pain and in second line of treatment. Dr. Ryan, welcome to the show.
Thank you for having me.
Absolutely, it's my pleasure. Before we dive into value-based care and our discussion in general, tell us a bit about yourself, the context of your work and chiropractic care particularly, and the Gonstead technology, which is your forte, I would say, if I may say it that way.
I would say it's my forte and my passion and my life's work. I absolutely love Gonstead Chiropractic. You know that if you love something, you don't work a day in your life, and so that's how I feel about Gonstead Chiropractic. So I'm honored to share it with you all. And if you can find information at gonstead.com as well as totallifechiropractic.com. And Gonstead Chiropractic is based on the foundation principle that we have to have a level pelvis, and your spine sits on your pelvis. So you have a level pelvis and each vertebra sits on the one below, obviously. So when you have a balanced level pelvis, you have the best chance of being healthy and pain-free. So.
Absolutely.
Would you like to hear a little more about the Gonstead or?
Of course. Before going deep into Gonstead, give us a little, first of all, about yourself. Tell us about, yourself as a chiropractor, but, you can start about, yourself, your life journey. This way, you tell us your story. It's very interesting to have, somebody, I will tell you why as we go along, to discuss with you because, Dr. Erdik talked about, CMS is, people like you and I sitting in some fortress in Washington and trying to think about how to save Medicare, because Medicare is, every 2 years talking about going bankrupt. So they are coming, the Affordable Care Act has put the foundation of at least, brainstorming new ideas. So, second line treatment now, there's a whole slew of possibilities. And we're talking about, again, we're still in the preventive phase. So tell us a little bit about how you see the chiropractic care fitting in the healthcare landscape.
Well, okay. So that was a lot. So I'll get started. So I went to chiropractic school to play rugby. That's why I'm a chiropractor. I went there to play rugby and I learned about a healthy lifestyle. And in chiropractic school, there are many different techniques. And I found Gonstead Chiropractic to be the one that was most that spoke to me, and the one that made the most sense to me, and that's how I embraced Gonstead Chiropractic.
Okay, it's based on the pelvis with the spine being held straight or the best possible.
Yes, and so I'm in practice 24 years here in Randolph, New Jersey, and started off a very strong insurance practice. And when people ask me if I take insurance, the answer is I take all insurance that pays for chiropractic care, which is changing by the quarter of the year, as you all are discussing. And we accept Medicare, and Medicare does not pay for the first day. So someone will come in and they'll say, but I have Medicare. And so, but we have to do our initial examination, our evaluations, our x-rays. And so people have to pay out of pocket for those x-rays. And they're not happy about that. And you guess where they tend to blame. They want to have issue with us, but we are sharing with them. We are following the guidelines, and which no longer pay for the examination and the x-ray, but they'll pay for the Medicare services. They will pay in chiropractic about 30 visits to get someone through the initial intensive care in our office.
Okay, very good, because there is a straight reimbursement of the services, but not the side. I mean, if you need a pelvis X-ray, that's not reimbursed. Okay, I get that.
Right. So the X-rays that I take are actually a full spine, one from the front and one from the side, 14 by 36. They're fascinating the way it shows how the pelvis can actually affect everything all the way up to the top of your spine. And so let's see. Once again, I was saying that reimbursement used to be strong. Now there's a fee schedule, so they pay a portion of our fee. So that's where Medicare, unfortunately, is heading. I'm now a 90% cash practice, and that's wonderful, and it's less paperwork for us, but that's not by choice. That's because of what's happened with reimbursement.
Yes, physical therapy is a straight reimbursement. Chiropractic care, there has been also, a whole slew of others. There's acupuncture, but again, we see those getting more and more reimbursed in the different payment models. The traditional versus, the traditional is a straight payment, but then the non-traditional forms of payment, there has been inclusion of, massage. You also do massage in your center, right?
Yes, we have massage therapy, but it's a primarily chiropractic.
Chiropractic massage. So this is where I wanted to go deeper. Is just relax and tell me what you think is the place chiropractic care has now in the context of preventive pain management. How do you go about that? And this is, of course, in the landscape of value-based care, but the landscape of, the opioid epidemic in America, where this is pretty, stunning that a country as advanced as America has a problem which is kind of like the 1970s. I mean, people take opioids for pain. I mean, that's like the lowest of the low kind of, attempt to kill pain. So that is there. I don't know if you have amongst your patients, do you have patients coming in saying, I'm taking way too much medication, can you help me? Do you ever get that, or you get referrals for that reason?
Quite often people come in and, medications have their time and their place, but these people are on these chronic medications for chronic pain. And that is where we see we get great results with helping restore the proper motion, because this spinal dysfunction, not moving, it interferes with all the afferent messages to the brain. So we will say that chiropractic helps restore the brain to body connection, but actually more importantly, it's the body to brain connection. When the joints aren't moving properly, that is what creates these these misalignments that result in fixations and degeneration. And here's the word, inflammation. Inflammation is what is causing these problems.
Mm-hmm.
And so we have these anti-inflammatories, and they can be very effective and very helpful.
Okay.
But when they're taking them on a chronic basis,
Absolutely.
now it starts to lead to these other problems in the organ systems, in the joints, in the dependency as well. So chiropractic is very helpful in breaking that cycle.
So focused on the back, going up and going up, going also down and towards the extremities. Can we say it's as straightforward as that?
Well, it absolutely. So I would say that joint position sense is absolutely affected when the spine is not moving properly, and those afferent messages are affected. That someone just knowing where their elbow is in sense is affected, knowing where their knee is. So these coordination problems are leading to even more and more breakdown because people losing their balance and their coordination as a result of these spinal. Let's not just say misalignments. Let's say there are fixations that occur, but there's also altered biomechanics. So it may not be a stuck vertebra. It may be a vertebra that's not moving the way it's supposed to.
Okay.
And that is enough to cause these joint position senses in the body that cause these problems.
I was looking forward to talk to you since such a long time, since we actually, were thinking of, having somebody with your experience come on the show. I myself, been treating back pain. I wouldn't say I'm an expert, but I have a lot of experience treating back pain, being an ER physician and also a surgeon. So I used to receive the patients when they are blocked, and they are, blocked where any movement is impossible. So I would be like, going into like heavy duty IV drugs and steroids, and then seeing if the patient needs to be hospitalized because, it
Right.
becomes impossible to just go to the toilet, for instance, at home.
Right.
That kind of situation. And then, of course, surgery is kind of rare in an emergency situation, but it has happened. I've seen that as well. But then, when you're looking at prevention, I mean, these patients, they come in, they in and out. First of all, there's life, there's work, there's family, there's kids. I mean, holding a baby in one position, even for a man, at some point, if you don't have a right posture, you will develop some kind of issue going forward. So how do you look at, how do you attempt in a preventive way to address the problem before it becomes out of control?
Thank you for that question. I would say that we encourage an anti-inflammatory diet.
Okay.
We encourage 100%. So, and if their medical doctor says that they can take omega-3 fatty acids, so probiotics and fish oil, we find to be very effective in lowering inflammation.
Mm-hmm.
Talk to people about even mindfulness, just breathing. I tell people, take 5 deep breaths. That helps calm their body. I mentioned walking. Brisk walking is so effective. I actually saw a study that people who walk briskly, they have a 20-year greater life expectancy. Now I'm reading someone else's research, but I was like, well, that's a pretty big statement. So we encourage the way they sit. Here we are sitting. I talk about sugar to the spine sitting to the spine is like sugar to the teeth. So how bad sitting is for us.
Yes.
We have these recommend spinal remolding, that you lie over backwards, because we spend so much time with your cell phone. Get your elbows up in the air. We're teaching these young children and adults to get in a better position when you're on your cell phone. So we talk about this structural problem, but as well as make sure that we're putting things in our body that are not creating more inflammation.
Absolutely. So, anti-inflammatory, what kind of, you're talking about NSAIDs, or you're talking about food that have anti-inflammatory properties like, I think, garlic? So
as I say, I realize who my audience is. I know that there's a time and a place for medications, absolutely. I do know that our food is a great medicine as well. So yes, having foods that are anti-inflammatory, trying to stay away from the bread, rice, and pasta, or not, maybe not the rice, but the white flour, the white sugar,
All the
the things
whites,
that
yeah, for
all the
sure.
whites that create the inflammation. So
I see. Okay, so you can throw in actually weight management also in there.
100%. Yes. So it's very interesting nowadays that you could even be in trouble for telling someone to lose weight. But obesity is an inflammation, and we are in the inflammation nation. And I didn't make that up, so you can use that as well.
No, absolutely. We talked about that over a couple of podcasts already, but yeah, totally.
So I would be remiss to just say with my point that adjustments to the spine in the proper position, the proper direction, help reduce inflammation in that disc, and that helps restore the proper motion and sets the body off to healing. But these adjustments aren't going to fix their unhealthy lifestyle. So that's why it's very important. And I start off with the simple thing of walking. Every adjustment, I make sure my patients understand that walking is helping reset that neurological pattern for proper biomechanics of the spine.
I see. We actually, on our end, we are. I mean, you're in second line, right? We are in first line in the sense that we are really the very basic first threshold of prevention. So our care coordinators, they are in touch with the patients in a manner that's I would say ongoing, permanent, and things like doing your activities of daily living. I'm talking about, of course, our focus is the geriatric population. Doing, of course, the fall assessments to kind of like identify those patients that need to be referred for more specialized assessment, and then pain assessment as well. So we are in that sphere where let's say we hand over to actors like yourself, and when you come in, then you add another layer of prevention. So we are in the same space of kind of like handling the ball so that it doesn't come to a guy like me at the ER who's receiving an acute problem to handle. So in that, I'll just tell you a little bit of what we are thinking of doing going forward. So as far as the painkillers go, we have to have better control over those because the epidemic is there. Opioid is used too much. I mean, people could actually just remove a bunch of what they're taking by just doing the proper things. That's one thing. And then the anti-inflammatory drugs come with their own set of side effects. So we're talking about renal failure. We're talking about ulcer in the stomach. So we don't want to go that way. So anything we can do to help these patients is fair game. And then we're talking about weight management. So we are going forward, really looking at how we can incorporate in our remote program also weight. Reason being, it's not, of course, it's very difficult. We're talking about a serious challenge here, but there are patients that can benefit from remote weight monitoring. We already do blood pressure and blood glucose as our connected devices, where we have live numbers that appear on the screen for our care coordinators to have and to feed to the provider, who is then able to make the decisions. But those are very straightforward. Blood pressure, blood glucose, you can adjust with a pill or a referral, and A1C testing and so forth. And then a new one that's come out, we are thinking of seriously putting that in our arsenal, is remote therapeutic monitoring, where you have Bluetooth connected devices on the canisters of pills to kind of like get an idea of how much patients are taking, or too much or too little. There's some medications that are life-saving. There are others, like painkillers, you would like to know if there's too much of that one that's opened. So that's going forward, we'll be having a lot of more addition to our arsenal of prevention. In that context, having the partnership of providers of partners like yourself is I think very interesting, because we are able to then again, leverage whatever we can on the preventive side in the chiropractic care. And Gonstead let's talk a little bit about Gonstead, because that's yours.
May I add to this
Sure.
subject before we talk concept? Obviously, balance and coordination are a major consideration. And one of I did this Titleist golf certification, and it was very interesting. There were medical doctors, physical therapists, and chiropractors all taking this. And we were learning about how the professional golfer can stand on one foot and raise their knee for approximately 24 seconds. And as we all stood up and did this, we thought we were in good shape. It was about 5 seconds before we're falling over. And apparently the pro can do it for a long time. And the treatment for this is to continue to do the test, continue. And as you could stand longer on that leg, they're saying this is firing up to the brain and helping your coordination and your balance. And so this is something that I have started with my patients, golfers, non-golfers, doesn't matter, and I would have them lean up against a door and hold one leg up to get started. And I have found that that's very beneficial.
I see. Okay. And Gonstead technology.
Thank you. Gonstead technology. So Gonstead is based on 5 criteria to analyze the spine. We first have visualization, where we watch you walk. We look at you, we have you take off your shirt, and we look at your back. We look at your posture, the height of your ears, shoulders, hips. Mm-hmm. That's step 1, it's visualization. Step 2, instrumentation. This is called a nervoscope. It is a dual probed instrument that reads the temperature on both sides of your spine, one level to the next as we go down.
Oh, wow.
So we use this every visit to help locate areas of inflammation. And there's a symposium coming up in October. It's amazing. The explanation of what this does is changing all the time, but we know that it works and it's reliable, but the explanation of how, that's constantly changing.
I want one of those.
And so I'm a practitioner, not a researcher. So
Sure.
I'm good at using it. I'll let those guys talk about that. But the next is static palpation, where we are feeling for levels, areas of inflammation, areas that are stuck, tight and tender muscle fibers, joints, fibrous tissue. That is static palpation. Motion palpation, we're moving your joints through the full range of motion, looking for areas of fixation, areas of restriction, areas of hypermobility. That's another thing. So one of the big things is laxity. The biggest thing is to not adjust the laxity, not adjust the hypermobility. And then finally, my favorite is the X-ray analysis, the full spine standing weight bearing, full spine digital X-rays, one from the front, one from the side. This will not only help me show where to correct the problem, but how long the problem's been there. I explain to my patients, if your car is out of alignment for a month, you may not notice, but if it's out of alignment for 2 years, those tires are going to be worn down. These X-rays will show us areas that are worn down, as well as areas that have developed fusions, osteophytes, bony spurs. Could also show the condition of the disc. So we put all of this together, we examine the patient, and that's how we're able to give a Gonstead chiropractic adjustment. It's about specificity. It's about being specific and only adjusting the areas that are fixated only back towards the midline, so the patient can get the best results.
How is it different from, I would say, conventional chiropractic care then? What's specific about Gonstead?
What's specific about Gonstead would be that analysis that I shared with you. Someone that we take these X-rays all the time on everyone except pregnant women, and so we're
sure, for the obvious reasons, yeah.
Yes. So I would say other techniques may not do all of those criteria. I would say it's not my job to say mine's the best. It's my job to say this is what I resonate with and this is what works for me, and this is where we get such great results. But I will see people post-surgical, and I will see people with spinal fusions. If we ever had time to put up x-rays, I have some amazing x-rays to share. But humbling as well, there's a young woman, she comes in with a prolapsed disc. Her discectomy is happening next week. I did my best, but I also shared with her the proper biomechanics in the spine. We need to make sure that we're keeping her spine moving as healthy as possible up until she's going to get that disc removed. So
surgery is the last resort with back pain, right? Because the results are very mitigated. I mean, if you have a very good surgeon, an excellent team, you're not looking at 90%. So, when you go into surgery, you want to have 99%, chances that you're going to be better. Of course, there's the risk of surgery, but it's a very difficult surgery. And, and back pain is a global epidemic. It's a prevalence, that's increasing around the world. People, work and sit. I mean, if you talk about remote, people work remote, don't take their cars and, a subway, but then they're sitting for, X number of hours, and then they end up with having, other problems. So
I will say that one of the things that I'm able to handle that comes in here are spondylolisthesis. Make sure that it's a stable spondylo, but we were able to get great results and without the x-ray, I would not know how to properly manage that. And then vertebra, the way they misalign is typically posterior. So with a spondylo, as you know, it's bone moving forward. And so we need to adjust the bone underneath it to properly care for that. So there's many different things that come into the office that I'm able to handle that I wouldn't without the proper criteria.
This is, musculoskeletal is a big part of what is it accounts for more than 15%, just musculoskeletal, more than 15% of the payments per member per month. So we're looking at a lot of resources that go into it. So if we can attack this problem on the preventive side is always welcome. In the context of the baby boomers are going into retirement.
Yes.
We are with a population that's of course aging for that reason, and so ulcer prevention, opioid overuse. We've talked about that. More than 75% of opioid use is due to musculoskeletal problems, of which 50% is for back pain. So there's, I think your work can really be, I think, because right now there's a need for other strategies than what we have. So, and from what I'm hearing, it's so. Tell us, what do you think of this? How do you see this problem of back pain in the country?
I think that stress is at an all-time high. I think it's chemical, physical, and emotional. And so, but let's not stop with the physical. We're, as you said, we're not designed to sit. We are on our screens. We're on our couches, and that just exacerbates the problem. I think that as a whole, our body, our country needs to move more. And I think that motion, as we all can agree on, that exercise and movement is the best thing that we all need to be doing. And am I answering your question?
Yes, of course. I mean, I would like to hear your perspective on this, because, I mean, to tell you, I mean, my idea of chiropractic care was it's focused on the back, and your Gonstead technology, you tell me, is focused on the pelvis and the back. The idea is the whole alignment, and perfect alignment if possible, right? So here we are looking at another way to attack this problem of back pains, which we can of course incorporate. And right now, the landscape of value-based care and the reimbursement, the non-traditional reimbursement models are incorporating more and more of the non-traditional strategies. And chiropractic care is totally into it. Massage also, yoga, acupuncture, these things where, if it's helping patients getting, better, and you're talking about better lifestyle, stress reduction, behavioral health, all these things are wholesome things, which, this is totally in line with where Medicare wants to go. Medicare doesn't want to go back to, the days of, before the Affordable Care Act. So
I will say that I want to just be clarified that my goal is to restore proper function and motion.
Mm-hmm.
And it's not my goal to straighten the spine. My goal is to make sure that the spinal motor unit is properly functioning.
Mm-hmm.
Well, there are techniques with the aim of straightening the spine, but I also know that there are reasons why there may be a curve there. So my job is to properly restore motion and the proper biomechanics to the spine, and that is what helps reduce the inflammation, increase mobility, and decrease pain, and increase quality of life. I'll share with you, though. Here we go. I wasn't going to say this, but we are not designed to sit. We lift properly. We lift improperly, bend improperly. So that is why I get adjusted on a weekly basis. So I'm adjusting over 300 people a week here in my clinic. I'm 51 years old. I'm a white collar laborer, man. I work my butt off. There's no way I could do what I do unless I'm getting regular adjustments every week. And that's how I'm able to maintain my lifestyle, my work. So
gotcha. I was ER guy, frontline worker, so I totally empathize with that. Now let's talk.
Dentists need. I mean, everybody. We need physical care.
Mm-hmm. Let's talk about COVID for a moment, because that has impacted everyone. How has COVID affected your work?
Well, I'm going to go back to that stress is an all-time high, and I'm busier than I've ever been since COVID. It was a rough first month, around April of 2020. But since then, the office has been getting busier and busier and busier. That I'm sure that's not a common theme for everyone, but that's what's happened in this office. That more people are searching for a solution to their stress,
mm-hmm.
And we've been able to provide that for them.
Have you been able to overcome the social distancing problem of your work? How did you go about that initially? Now it's getting better. However, may I just add this, and then I'll let you wrap up. So the BA.5 variant is out there, and there's, by one estimate, which I hope is wrong, it's as contagious as measles, and measles is the most contagious infectious disease out there. Now, what that means is, I think that calculation is wrong, but however, it has been thrown out there. I think it might be about half of that contagiosity, but what we are looking at is the pandemic is not gone away, and until we have what's called a pan-coronavirus vaccine, but we won't get into that for now. That'll be for another podcast. But the idea is to not, underestimate what is already been done as damage, and that we are not at any kind of safety yet of this virus. So, but in that context, how has your work been affected? Have you had to put in new strategies?
Yes, spacing out the patients, initially wearing masks, having plastic on the table that we would disinfect after every visit. We did do that for a period of time, but I would say that I agree with you, sir, that we're heading into a very interesting fall season here on many fronts. So.
We'll have to keep that, that conversation going for sure. Dr. Ryan, we are up for time here. Thank you for joining me. I would like to really applaud your coming on the show. This is, something very exciting to have, a healthcare worker like yourself in the space of prevention talk about how he attempts to, to deal with this epidemic of back pain and pain in general.
It's a pleasure. Thank you for having me.
Absolutely. And for our viewers, thanks for joining us. Next week, 2 weeks from now, we'll have our next podcast. And you can, of course, post your questions, watch the replay after the episode is downloaded and posted. And until then, I'm Dr. Avinash Jayaswal, and thank you for joining us at CCM Health Live Podcast. Have a good rest of your day. Dr. Ryan, And
Thank you.
everybody, and stay safe.